I'm Alyssa Changlao, your Medcorp Limited host for today. Welcome to our live webinar series, Connection and Care in an Era of Social Distancing. Today, we'll be discussing kidney health with Dr. Leslie Ann Roberts. Dr. Roberts is a specialist in internal medicine and kidney disease. After receiving her medical degree from the University of the West Indies, she became a fellow of the Royal College of Physicians of Canada and received her subspecialty certification in nephrology. Her nephrology training was obtained at a 2-year fellowship at St. Joseph's Hospital, Hamilton, Canada, a teaching hospital of the McMaster University Group. Dr. Roberts has been practicing all disciplines of nephrology over the past 20 years. She's currently an independent nephrology practitioner. Dr. Roberts, thank you for being with us today.
Thank you, Alyssa. Good day, everyone. I hope you all can hear me. Is that right? Okay, today we are going to speak about our kidneys. There's what we call COVID-19. Everyone is going to change the current way at which they function, certainly now and in the future. And one issue of change that I'm hoping that we'll all use is to take better care of our kidneys. So let's talk kidney health today. Our kidneys are two bean-shaped organs which each measure between 9 and 11 centimeters in their longitudinal diameter. That's about the size of one's fist. We know that they get smaller as they lose function. They are situated retroperitoneally so that they are often blamed when a person experiences pain in their back. Unfortunately, though, at least 90% of kidney disease is painless and can often only be determined by examining the blood or the urine. So when symptoms related to malfunction of the kidneys does occur, you find that you've already lost a considerable amount of function. Doesn't that remind you of something? Yes, it is. COVID-19, because at least 80% of the patients who are affected with this disease tend to be asymptomatic or have mild disease. But even so, they are still capable of spreading the virus. Like COVID-19, the existence of kidney disease has an ominous ring for many, and it should. But we should remember that kidney diseases comprise such a wide spectrum of disease severity that you really cannot lump everything together. There are some diseases that make a patient just a little anxious, like if they have a bladder infection or a simple cyst in their kidney. They may get more moderately anxious if the doctor tells them that they have nephrotic syndrome or they are now becoming diabetic or hypertensive. And certainly they get very, very anxious if they are told to have chronic kidney disease or if they have end-stage renal disease and they need dialysis. Kidney diseases are no respecter of age, gender, or ethnicity. Some diseases develop because of one's lifestyle. Others are hereditary or congenital. Some occur just on one single occasion, while others keep recurring and progressively damage the kidney and eventually may lead to kidney failure and even death. With such a wide spectrum of disease, you would realize that one suit does not fit all kidney diseases, and certainly one tablet cannot cure all. So this morning, what I plan to do is to speak about how we will be able to determine if one has a kidney disease, or two, if we do develop a kidney disease, what do we do? Thirdly, what do we do? How do we manage patients with significant kidney disease in the face of this COVID pandemic? So some tips to look for if one has a kidney disease. Well, as I said before, most kidney diseases are asymptomatic. And the bottom line is that everyone should have an annual physical examination. Yes, we'll go and see our doctor if our legs are swollen, if we have some back pain, or if we think we have some urine abnormality. But remember that kidney disease and significant kidney disease tends to be asymptomatic, that is, without symptoms. So, therefore, everyone over the age of 18 should have an annual physical examination, and everyone over the age of 50 must have an annual physical examination. And this annual physical examination must include blood and urine tests. People who should be targeted are those who are overweight, those who have some past history of having problems when they were pregnant, those who were born prematurely, those who have family histories of diabetes, high blood pressure, kidney disease, cardiac problems, and those who may have been told sometime in the past, possibly on an employment medical, that they have a touch of blood pressure or a touch of sugar or a touch of protein in their urine. Such things do not occur. And when those issues are said to have happened, they must be followed up. Once you've been given a clear pass on your physical examination, it just doesn't end there. Everyone must now keep the eight golden rules. We must keep fit, we must be active, we must keep our weight down, and to do that, we must eat healthily, drink enough water, do not smoke, consume alcohol in moderation, and monitor our blood pressure and blood sugar regularly. And if we are in that high risk group that I just mentioned, we must check our kidney function on a regular basis. Good. So here we are, a good physical examination, and we are practicing our eight golden rules. But as I said, you must have an annual examination and there must be follow up, particularly if some abnormality was found when they checked your blood, your physical examination, or your urine test. That abnormality, if found, must be rechecked in 3 months, even if you feel no differently and even though nothing has happened to us. And that is where our problem lies. We do not follow up. We need to see if our fasting blood sugar is still high. We need to see what our hemoglobin A1C is. Is our blood pressure still elevated? And if that touch of protein is still there or if it has disappeared. If nothing has changed, then further investigations are necessary. And this is where it becomes incumbent on you that you must know your numbers. You must know your weight, height, and body mass index. This should preferably be under 30. The recommendation is that between 25 and 29, you're still considered overweight. But we'll aim at least to see if we can get everybody under 30. And if we can be maintained within 25 to 29. Your blood pressure readings you should know, your fasting blood sugars you should know, and as well you should find out in your urine if there's any sign of protein or blood. So, it has been determined that you have some sort of kidney disease. A diagnosis then has to be made as to what is the kind of kidney disease you have and what then is the effective treatment or management. Do you have diabetes? 1 out of every 4 adults in Trinidad have that. Are you hypertensive? 1 out of every 6 people in Trinidad have that. Do you have an autoimmune disease? Do you have a hereditary disease? But maybe you do have a significant kidney disease, which we will term chronic kidney disease. Well, 1 out of every 10 adults have such. So, what do we then do when we recognize and we want to manage someone who has proven to have some form of kidney disease? Well, there are 5 basic things that we need to do. The first is that we need to decide what is the severity of the kidney involvement. That needs to be established. And how do we establish that? We look at our ultrasound, we further examine the urine, we do a quantitative assessment of how much protein is in the urine and we do further blood investigations. Once we identify the underlying condition, we have to treat it. We need to use specific medication that will control the underlying disease. And we have to aim for our optimal targets to control one, our blood pressure, and two, our sugar. There's no specific medication unless we identify a frank disease. But it is so important once we have established that there's some sort of kidney disease that we always have our blood pressure and blood sugar perfectly controlled. In addition to that, we need to avoid any further poisons that may damage the kidney. And what are these poisons? Well, they're simple things. We need to ensure that we never become dehydrated. Yes, everybody says you have kidney disease, drink lots and lots of water. But you should depend on your doctor to instruct you as to how much water you should drink. You don't want to drink too much water because then you may sometimes overload yourself and end up in heart failure and then get very swollen. On the other hand, you do not want to make yourself get dehydrated because if there isn't enough fluid going through the kidneys, then you are going to further damage that kidney. Avoiding nephrotoxins, a big word, it's just toxins which can damage the kidney, is exceptionally important. You already have a problem, you don't want to make that problem any worse. Certain drugs can do that, predominantly the drugs that we use for our joints and our pains in our joints after we exercise, and sometimes other over-the-counter drugs that we may use in our cough medication. We always need to inform any doctor that we are seeing that we may have such a problem, because then they would need to use different medications on you or change the dose of the medication that you may be on. The other very, very important thing is that all people who have significant kidney disease must be on the lookout for cardiovascular problems. That is, heart failure, heart attacks, and bad rhythms in the heart. People who have chronic kidney disease generally die not from kidney problems, but from cardiac events. And if you have diabetes in addition to having a chronic kidney problem, your risk of heart disease and dying from a heart attack increases exponentially. The other thing that you need to do, as we had mentioned before, is to keep on practicing those 8 golden rules and know your numbers. And as I had said before, even after we are diagnosed and we are on medication, it is critical that we get our regular follow-ups. How often should we be followed up? Well, that depends on what your GFR is, and that depends on what your creatinine value is. And the most important thing that dominates that is how much protein is being spilled in your urine. The more protein that is spilled generally tells you that the more damaged the kidney is and needs to be monitored more regularly than if you had less protein spillage. I hope you're keeping your questions, and maybe, if I can refer to them later on. So we have found the people who we think are normal but really have some kidney disease. It may be just mild kidney disease, but we have told them what are the bad things that they need to look out for, and we have told them what they can do so that they can have regular follow-up and pick up things before it becomes detrimental to them. So, what are the tips to recognize and manage people who have established chronic kidney disease? Well, it's all of the above that I've just gone through, but 2 of the most critical things are the control of your blood pressure. An optimum blood pressure that we would like to aim for is between 130 to 140 over 80 to 85. However, if you have a massive amount of protein spillage, or in some people who have polycystic kidney disease, that's a hereditary disorder, you would aim to try and keep your blood pressure even lower because that has been shown that that would decrease the rate at which your kidney disease will digress. And that's another thing I need to mention about it. Once you have chronic kidney disease, and that is a clear definition, and the doctors will let you know if you have that or if you don't have that. And they can tell that from your ultrasound, which has now shown shrunken kidneys, the presence of a significant amount of protein in the urine. You would realize that this disease is going to progress with time. And your purpose is to make that progression occur as slowly as possible so that those kidneys you have will carry you to the end of your days. And the couple of ways at which that is going to happen is by optimizing the control of your blood pressure, optimizing the control of your blood sugar, and your diet. I cannot emphasize how great the diet is. It's not so much decreasing the protein in the diet, but eating healthily and watching the amount of salt that you are consuming. Because too much salt is going to lead to further swelling. It is going to lead to your blood pressure being uncontrollable, and that is so important in maintaining your kidney health, a good blood pressure. A very important thing that needs to be done as well is that you need to maintain your volume status. Too little fluid in your body is just as bad as too much fluid. What we aim for you to do is to try and be, a big word, euvolemic. That is that you have enough fluid in your body. You don't get dehydrated, so that if you're having bad bouts of diarrhea or vomiting, you just not sit back and rely on that. After 24 hours, you consult your doctor. If you find that you're not breathing properly or your blood pressure has gone up considerably from what it generally is, or you're having a chronic cough, it may not be always due to medication. It may be because you have too much fluid on you. You need to consult your doctor and do something about it. In a similar vein, any intercurrent illness can make things worse. So if you develop some occult infection that you can very well be prone to because you're diabetic, or if for some reason you start realizing as a man you're getting older and more dribbling is happening, and you may be getting up more frequently in the night to pass urine, you need to check to make sure that your prostate is not very much enlarged and it is now causing a problem on your kidneys. Because whatever is able to be reversed, that needs to be dealt with very expeditiously. And you need to keep in touch with your doctor because, as I said, the disease can be progressive, or not can be, is progressive. So you would need continuous education and counseling on how to deal with what is going to happen as things, if they do, progress. So we now come to the management of patients with significant kidney disease, not just this little simple cyst, but people who we have said now have chronic kidney disease, maybe due to their diabetes, maybe due to their hypertension, maybe because of their hereditary problem, which the most common one we see is polycystic kidney disease, which is a autosomal dominant condition, which means that it spreads from mother or father down to the children and from the children to their offspring, and it goes through generations. So you will definitely find out what is happening there. So, what happens when these patients or those who have reached to the stage of dialysis are diagnosed with COVID 19 or suspect that they have been in contact with someone who has had COVID 19 or has been tested positive for COVID 19? These patients are so vulnerable. Why? They are older. Many of them are over the age of 60. All of them have several comorbidities, whether it be diabetes, hypertension, cardiac disease, and many of them are dependent on everyone else. They live at home with their families. They need to be dropped to dialysis. They need to be, some of them may even have to be taken public transport to get to their dialysis on a regular basis. So they are really in the highly vulnerable grouping. And what would we suggest for them? Well, they need to continue doing everything that they have been accustomed doing, but they have, as we now know it, they need to follow what has been preached by our Prime Minister, what has been preached by our Minister of Health, our CMO, and our basic national policy. They need to be aware, they need to separate, and above all, they need to stay at home. There are some other things that they most probably need to do. They need to be aware and to know what are the telltale signs. Firstly, if they develop a fever, if they have a sore throat, if they have lower respiratory symptoms, for instance, a dry cough, and most importantly, if they have been exposed to anyone who has had any recent traveler, anyone who has been tested positive, and as such, they have been out and they have been out there. I cannot emphasize enough that these people need to be at home. That's the only safe place for them. They need to be aware that this disease is spread by droplets and also by direct and indirect contact. Their airborne history isn't quite known, but we do suspect that there's some airborne contamination. So they should use a mask. The mask helps them, but it doesn't protect them. They need to stay at home. Staying at home means that you still need to practice good hand and respiratory hygiene. Staying at home means that you do need to come for your dialysis regularly, if that is what you have been doing. And staying at home means that you do need to communicate to your health professional, whether it be your dialysis nurse or to your doctor, if you develop any new symptoms, particularly those that I have just mentioned. Yes, COVID 19 can affect the kidney, but it isn't a great, but the manifestations of COVID 19 on the kidney have generally been not the presenting manifestation. They have seen it in people who are decompensating and most probably will end up in ICU and on a ventilator. These people, if they develop acute kidney injury, generally signify a poor prognostic indication. If you happen to be on dialysis and and come down with any of the symptoms, your first duty is to inform your dialysis unit. Your dialysis unit will let you know how you proceed from there, because arrangements have been made that you'll be able to continue your dialysis if you become COVID, if you are proven to be COVID positive, if you, and they will make arrangements to have you swabbed and your dialysis be carried on in a safe and secure way, which will cause no embarrassment to you or to the health worker who has looked after you for so many months, weeks, and years. So you see that significant kidney disease and COVID-19 share so many things in common. The disease process and management for COVID-19 as well as for chronic kidney disease is a marathon and not just a sprint. We must be prepared for a long haul. We must always be in touch with our health professionals and continue to do what we are doing at the start all the way through. Persons over the age of 50 are the most vulnerable, and therefore these people are special and must, above everything, maintain the stay-at-home policy and be the ones who will be able to detect this as soon as possible. The situation in both is completely fluid. We think we know what we know, but we could be blindsided at any one time. We don't want to get totally confused about what we are doing. We need to stick to our basic principles and guidelines. Our 8 golden rules that we have heard, we must continue to practice that. Our diabetes and blood pressures must be kept under control, even with whatever diet we are now going to be consuming. We need to stock up on our medications. We're not going to panic buy and buy 6 months worth of medication, but we're not going to let the medication run out and then 2 weeks or a week down the line say, oh, I haven't taken medication for a long period of time. We will continue to do our dialysis, but we always need to be prepared for the unexpected because we really don't know what is around the corner. Thank you.
Thank you, Dr. Roberts. That was amazing. So much valuable information. We have some questions from our attendees. Let me just have a look at them. We have some diet-based questions. You talked quite a bit about the importance of having annual checkups, of keeping that dialogue open with your physician. What type of physician do you recommend patients start off with if they're not yet chronic kidney disease patients? And then you mentioned the follow-up. Who should this follow-up be with?
Okay, well, everyone for their annual checkup should go to their family doctor, their general practitioner, whatever. But I think that should be their first port of call. In addition, regardless of if they're going on to see specialists, they should always be in touch with their general practitioner. So that's their first point of call. When you go to your general practitioner, you will most probably know that he will be doing his physical, he'll be doing his examination of your blood, he'll be dipsticking your urine. If you are found to have any abnormality, you should follow it up at least after 3 months. Do not wait until it's broken to fix it, because as I keep saying, a lot of kidney disease is asymptomatic. So yes, you will attend to the quick things and it will be fixed one time. But if there's something in your history, and I highlighted the people who may be at increased risk, those with the family history, those who had maybe told that they have a bit of this or a bit of that, nothing to worry about, those things should be delved into. Maybe something simpler as just losing weight and changing your lifestyle and exercising a bit more. But those are the things that you need to pay attention to initially. Once that is done and you have had your follow-up over the next 3 months, and you have either become normal again or they have found something, your general practitioner will then decide if you need to move on to see a specialist. So at
Okay.
all times, I feel that a general practitioner should be your first port of call, and then subsequent to that, he or she needs to be always there for you and with you, but will decide if you need to move on to see a specialist.
Right. He or she would allow that continuity of care because, as you said, sometimes you can have cardiac um, impacts as well. So when the nephrologist is seeing you, the cardiologist is seeing you, that general
Yeah,
practitioner
and
is
that really bugs the
anchor.
patient. This is where the importance of the general practitioner, because he is like the pillar at the back, because you're hearing instructions from the cardiologist, instructions from the kidney specialist, instructions from your diabetologist. I mean, so many instructions, you just feel sometimes to shove everything in a paper bag and just throw them all out. This is where the GP, keeps you grounded and kind of further keeps you counseled that you will know that this is just continuity of care and this is what you need to do.
Right. Well, we have a lot of questions about water. I'm going to read a few to you so you could address
Okay.
it in the round. Um, how much water should I drink per day? Second question is, if I don't have kidney disease, is there a limit on the fluid intake that is advised? And third question, I'm 40, I don't drink enough water every day, and I probably have not for my lifetime. How late is too late to avoid kidney damage?
Wow. Several questions. How much water should a person without kidney disease drink? There's no guarantee that you need to drink 2 glasses or 5 glasses or 6 glasses. What a person without kidney disease needs to do is to ensure that they drink as much water as when they are thirsty. Now, sometimes working in an air-conditioned environment, you find you don't feel thirsty. However, if you can tell yourself, listen, I am going on an average, I am a normal person is most probably going to pass about 2,000 cc's of urine a day. So if we account for what we call insensible loss, that's sweating, that's running around, we should try and drink between 2 to 3 liters of fluid a day. That is provided we have no type of kidney disease. People who have kidney stones or family history of having had a kidney stone in somebody in their family, they should definitely increase the amount of water that they drink. People who are exceptionally active, when I say active, just basically, you ride every day, you play tennis, you really take part in a lot of exercise, they too need to drink more water. Now, the question is, if you have kidney disease, and this is what I will call significant kidney disease, and you are going on to dialysis, those are the people who may not need to drink as much water as necessary because they most probably have an ongoing cardiac problem and you don't want to make them overloaded. The other thing is that people who take in too much salt would tend to feel increasingly thirsty and drink too much water. So this particular group of people who you find are hypertensive, maybe bordering on having some cardiovascular disease, they need not to drink as much water as the rest of people. And the person who is 40 who has no kidney problem, now is a very good time to start. It's better to start later than never.
Okay. And we have another question about, can taking supplements such as vitamin B12, etc., cause further damage to the kidneys?
Vitamin B12, as other vitamins, don't really cause damage to the kidneys. you take supplements if, there's, the world right now is just full of supplements. There's everything for everything. My recommendation with supplements is if it's not harming you, then I have no problem with it. But certainly, if somebody is in a high risk group, somebody has had previous kidney injury and they have not further recovered, then I don't advise that you take things like creatine or you go on a very high protein diet, because you would find that your amount of protein that is being leaked out and passing through your kidney is going to be toxic to it, and it's in high quantities. So supplements, yeah. The other thing that I would recommend is people who have some degree of chronic kidney disease, do not overdose on vitamin C. You like to boost up your vitamin C when you think you're coming down with an infection. I don't recommend that. Neither do I recommend that somebody who has kidney disease significantly or even on dialysis, that they use magnesium, because those are some of the minerals that cannot be excreted by the kidney and can give rise to toxic problems.
Right. So you should definitely be in touch with your nephrologist if you're going to be taking those.
Yeah.
We have a question. We have two questions. One is about blood pressure and one is about blood sugar, which you touched on. The first is kidney disease and high blood pressure a chicken and egg situation? What percentage of kidney disease patients have high blood pressure and vice versa?
It's definitely a chicken and egg situation. So how do I start it? Quite a number, I would say at least 80% of people who have kidney disease will have an elevated blood pressure. Sometimes you find once you have started dialysis, if your blood pressure is being driven by your volume overload, you may not find that you need blood pressure medications. But in a lot of patients, your blood pressure is sometimes the first manifestation of kidney disease. If you find that you have a kidney problem and your blood pressure is high and there's a marked amount of protein in the urine, then that most probably caused you to have kidney problems. In that you will have, you start off picking up the high blood pressure as your first sign that there may be something happening with the kidneys. And then in a certain group of people, that blood pressure becomes very difficult to control, or a group of people that seem to have a problem with the lining of their blood vessels that seems to accelerate the development of kidney disease. So you have high blood pressure, kidney disease making the high blood pressure worse, and then in a certain group of people, making the kidney disease get even worse faster.
Right. Okay. That's a very comprehensive explanation. So for our attendee who is asking, what is the relation between a touch of blood sugar and your kidney health?
Okay. The touch of blood sugar means that, it's nothing to worry, nothing that you need to be worried about. Don't worry about it. But it is very important that you worry about it and you make sure that that touch disappears, because if you just figure it's nothing to worry about, that touch as time goes by is going to develop into full-blown blood pressure, blood sugar. And maybe it wasn't a touch. It was just an early sign that you were diabetic. And prolonged diabetes that has not been controlled in our population accounts for 90.99% of the people who are now on dialysis. So we don't ignore things like a touch of blood sugar. We need to make sure what it is that caused me to have this touch of blood sugar. Was it my family history? Was it the fact that I'm overweight? Was it the fact that I'm not eating healthily? Was it the fact that I might have, as a woman, I would have had gestational diabetes. And I presume all of this will be discussed in more detail when you do your webinar on diabetes and COVID or diabetes by itself. But I just bring it up to say that you need not to ignore things like a touch of blood sugar because it most probably will mean something in the long run.
And we have a follow-up question. How does one control or get rid of that touch of blood sugar?
Well, as I said, if the doctor tells you have a touch of blood sugar, find out from him what it means. Does it mean that I have too much sugar in my body? What do you mean by a touch? Is it that it's not very marked and it might be able to be controlled on diet alone? Or is it that because of my family history, you are thinking it's there? Be precise, be specific. If he tells you, listen, it seems as if you're diabetic, but maybe it's because, do further investigations to either confirm whether you're pre-diabetic, whether you just have carbohydrate, what I say, some glucose intolerance, or whether or not you have frank diabetes. If it is that you're in the first two, maybe by changing your lifestyle, you can get these things under control. And if you maintain them under control all the time, then you will not end up with being one of the casualties of being in end-stage disease. But the issue is, one, it has to be identified, and the follow-up isn't just for 2 months or 3 months till you get rid of it. The follow-up is lifelong. You can't lose weight for 3 months, then have a normal blood sugar, a normal blood pressure, and 3 years down the line, now go and test it again when you have put on weight about 30 pounds over the 3 years. It needs to be an ongoing battle. It is a marathon, not a sprint.
Right. So lifelong commitment to our own health.
Exactly.
One of our attendees is asking, what is a dangerous GFR for a well-controlled diabetic?
A dangerous GFR for a well-controlled diabetic. Okay, so GFRs have been staged, and it is recognized that once your GFR is under 60, that you most probably are in the realm of some impairment of your kidney function. If you are a well-controlled diabetic and your GFR is under 60, what you need to do is to see what is happening to that GFR lifelong. Is it dropping by a half within the next 6 weeks? Then that's something else is going on. Do you have a significant amount of protein in the urine? Is it under a gram, or is it greater than that in a nephrotic range? Which, as I mentioned before, all things that will tell you how fast you're going to progress. So any GFR in a well-controlled diabetic is significant, but the more important thing is how much protein in the urine is associated with that GFR, and how fast is that GFR changing. So again, keeping in touch with your doctor, whether it be your GP, your nephrologist, your endocrinologist, your whoever, and lifelong commitment to follow up.
Can you tell us a bit about whether there's a link between cholesterol issues and kidney disease?
There isn't, well, as far as I am aware at this point, there's so many issues with the cholesterol. One of the major things with the cholesterol is the effect that it's going to have on your blood vessels. And essentially, the kidney is full of blood vessels. That's how the kidney works. So if you're going to have damaged blood vessels because of high cholesterol elsewhere in the brain and in the heart, you are going to have damaged blood vessels in the kidney because of high cholesterol. And if that happens, obviously your kidney function will not be as good as it should be. So I think that's the general link that you can look at.
Okay, thank you. We have one last question from an attendee. We talked about COVID-19 and kidney health. Do other viruses such as chikungunya or dengue have an overly negative impact on kidneys?
I would have to say that the direct effect on kidneys may not have been as not as marked with chikungunya and dengue. What the effect that you see in all of these viruses is particularly chikungunya and dengue, is the indirect effect of the complications that can occur. The dehydration, the third spacing, the lack of enough volume passing through. What we are definitely seeing with the corona type virus is that you have a direct kidney, you have a direct viral cytopathic effect on the tubules of the kidney as a result of the coronavirus. It has been seen, though, to be more marked with the SARS and the MERS, those disease syndromes, than it has been with COVID-19.
Okay. Well, all of these things are very appropriate for our Trinidad and Tobago context. So Dr. Roberts, thank you for taking the time to share this wealth of information with us today. I know that we took a bit more of your time than we thought we would, but it was just so much information that it generated a lot of excitement and questions in our attendees.
Thank you very much, Alyssa. And more importantly, thank you for bearing with me.
It was our pleasure. Thank you to all who attended today's live webinar. Please register for tomorrow's webinar where we're going to be discussing diabetes. We'll close the loop on the blood sugar, and join us for Friday's chat on how we can best cope with that added stress that the coronavirus has brought to daily life. The details about webinar registration can be found on St. Clair Medical Center's Facebook page. So I want to wish everybody a great day that's filled with that kindness and gratitude we talked about earlier, and we can't wait to see you tomorrow.
Thank you, and stay safe, everyone. Stay at home except for absolutely essential business. People who have chronic kidney disease and on dialysis, please, please, please stay at home. But please do come for your dialysis, and please talk to your general practitioner and your doctor if you have any concerns. This is, we must maintain that contact. That's the only way we will go forward. Thank you.